Yeah, hello. Good evening, everyone. So let's begin the lecture. The topic is going to be on the final diagnosis, treatment planning, and prognosis. This is going to be the last lecture in diagnosis today. So, so what do you mean by final diagnosis? The definition of final diagnosis is a firm statement regarding the etiology and nature of pathologic process affecting the patient. Means you're pretty sure what exactly the problem is there in this patient because you're using your knowledge, skills, everything to diagnose what is the problem in the patient, so that you're confident, 100% confident that this is the problem. So you know the exact etiology and nature of pathologic process affecting the patient. So you also have prognosis after this final diagnosis. As I've been telling you, what is prognosis? Prognosis means you need to predict the outcome of the disease with and without treatment. Means how the patient is going to do with the disease, whether he's going to recover and stay long without the disease or not. So that is exactly what is called as prognosis. Okay, so once the final diagnosis and this thing is done, the aim of the diagnosis is so that you provide a treatment plan to the patient. Now let us look into what are the exactly objectives of the treatment plan. The main objective is to cure the patient from the disease and to provide relief from symptoms and to provide nutritive and psychological support and to prevent the occurrence of the disease. So these are the four objectives of the treatment plan. Now, when you see here nutritive and psychological support, this is important from dentist perspective because because of the tooth pain, the patient will not be able to eat properly or they might be psychologically disturbed. So you need to provide support for that as well. And in the last, you should plan the treatment such that the disease doesn't reoccur again. So you need to prevent the occurrence of the disease. So once the treatment plan is done, keeping in mind the objectives of these, there are two phases of treatment plans basically. So one is the immediate treatment plan and another one is the planned treatment plan. It's not visible here, but there are two. One is immediate and another one is the planned. Immediate means local and pharmacological, means you need to give treatment for the acute infection for which the patient has. So that is called as the immediate. And planned is if the patient doesn't have any pain or acute infection, you can plan it in a proper manner. Okay, this is what I was telling: prognosis, prediction of the outcome of the disease with and without undergoing treatment. Okay, coming to the treatment planning. Now, there are some concepts of the treatment planning as you can look at in this slide. The dentist goal is to provide the best possible dental treatment to each and every patient individually. So this has to be kept in mind, that you need to provide the best possible treatment for each and every patient individually, because even though two different patients have the same problem, the treatment might be little different for each of them because of the underlying systemic condition or any other problems which the patient has. So it is the dentist's goal to provide the best dental treatment possible to each patient individually. So this we are providing to the patient by gathering of information and doing the diagnosis. Okay, now let us look at the concepts. What exactly is a concept? See, treatment planning is a strategy that may be changed or adjusted according to the patient's needs. Suppose if the patient doesn't have any pain or acute infection, you know what the patient desire, that you can treat the patient. So it's a strategy. I mean, it can be changed or adjusted. You cannot say that you want to plan the treatment exactly like this. Sometimes you might require some changes if the patient doesn't have any acute infection or pain. Okay, now let us look at the formats of treatment plan. Basically, there are two formats in the treatment plans. One is the general format. The second one is the flexible format. Okay, in the general format, we basically have four phases. Phase 1, priority treatment. Phase 2, disease control. Phase 3, restoring function and aesthetics. And phase 4, reevaluation and recall. So these are the four formats of treatment plan in the general format: phase 1, phase 2, phase 3, and phase 4. Now coming to the flexible format, the name itself, what do you mean by flexible? You have to be flexible. A rigid treatment plan is not suitable for all patients. Why? Because new information during treatment. Suppose you start the treatment today and after 1 week the patient comes back, he has a different problem. So, this is a new information during the progress of the treatment. So it needs modifications or changes. So just remember, you have two formats of treatment plan: general and flexible. General usually has four formats. but flexible, you can adjust it according to the progress or the needs. Okay, now some examples of the general format. Phase 1, as I told you, priority care means you need to eliminate pain and manage acute infections. Here are few of the examples for these. Treatment of pulpally involved teeth, that is emergency endo. Suppose you have to do an emergency procedure or extraction. This comes under priority care. Just remember, priority means very important. Mean the patient has acute pain or infection. For these things, the patient needs to be treated. So this comes under the priority care. Or one more example is treatment of painful conditions, periodontal, such as pericoronitis. I'm sure you know what is pericoronitis. It's the inflammation of the pericoronal area, especially in the mandibular third molars. And might be some of you might have experienced this as well. So this is an acute infection or acute pain which needs to be done under a priority care. And suppose you see some, another example is you see some suspicious bony or mucosal lesions. I mean, it might be some big risks to the patient when you see some suspicious bony or mucosal lesions. That also should be under priority care. And one more example here, temporary restoration in teeth which have caries near to the pulp. Suppose you feel on the radiograph and clinical examination that the caries is very near to the pulp. It is better to do it on a priority basis, because once the caries reaches the pulp chamber, it has to go for endo, so the treatment planning is going to change. So for that reason, you need to take this under a priority care. Okay, coming to phase 2, disease control. This is to control all disease processes, but you cannot eradicate all diseases. Here, what basically your aim should be is to control the disease processes. So suppose if the chief complaint is not managed, he ought to complete it in. If not managed, it has to be completed here. Or oral hygiene instructions like scaling, mouth washes, and all these things can be prescribed here. And most of the oral surgery procedures, if the patient doesn't have any pain, periodontic, endodontic, orthodontic, and occlusal analysis. This should be the order in phase 2. Suppose if the patient doesn't have any severe acute infection or pain, then you can go according to the order. Better is to go for oral hygiene, that is scaling first, and then go for the other procedures. Coming to phase 3, obviously, it's the restoration and function of aesthetics. This is mostly the prosthodontic work. Either it can be removable or fixed prosthodontic works. So here, you have to eliminate the remaining areas of dental caries or decay, and you should try to restore the mouth to full function and aesthetics to restorative procedures, or it can be prosthodontic procedures. Another few of the examples for phase 3 restoration of function and aesthetics: placement of amalgam or tooth colored restorations, all necessary procedures prior to prosthodontics, placement of crowns and fixed bridges on complete or removable partial denture. Just see here, it's either restorative or most of the prosthodontic procedures which you're going to do under phase 3 restoration of function and aesthetics. This is also an important part of your treatment plan, which mostly you have to do it actually. It is a phase 4 re-evaluation and recall. You should always try to recall and re-evaluate the patient after the treatment. Follow-up appointment, that is endo or perio treatment, has to be done, and routine recall examination checkups. What we tend to do is mostly, once the treatment is done, we don't recall most of the times we tend to do that, we don't recall the patients. But this should be a part of your treatment plan, because once you do some endo procedure, you need to recall the patient maybe after 6 months or 3 months to check how the patient is doing. So this has to be a part of your treatment plan for your successful treatment plan. So basically, in the general format, what I have discussed is 4 phases of treatment planning. In the general format, phase 1, management of pain and acute infections; phase 2, disease control; phase 3, restoration of function and aesthetics; and phase 4, re-evaluation and recall. So that is about the phases of treatment planning, general and flexible format. Now let us go to the factors which influences the treatment plan. Means what do you mean by influence? Influence means, when you plan the treatment, you want to have a set of designed treatment plan for each and every patient. Maybe there is some factor in the patient which is not allowing you to do the normal routine dental treatment plan as you have planned. Because why? One example is the patient's health. Simple example, suppose the patient has some underlying medical condition like diabetes, hypertension, or cardiovascular disease, or some female patients who is pregnant, you cannot go for the routine dental practices. You need to take care of that particular problem, and then only you can go. So the patient's health is going to influence the treatment plan. Similarly, there are seven more factors which I'm going to discuss one by one as I go through the slides. The second one is the patient's age. The third one, patient's expectations, psychological factors, existing dental conditions, the prognosis, emergency treatment, financial considerations, and operator experience. See, this is also important. Financial considerations in private clinics, they charge money, so maybe some patients they will not be able to afford, and the operator experience also will matter. I'll discuss all these things as I go through the slides. Okay, one example how it's going to influence your treatment plan. The patient's health, as I told you, medical health status of the patient may need some modifications. Example, you might have to, suppose there is a cardiac problem, infective endocarditis or some other problem in the patient, you need to give prophylactic antibiotics to the patient prior to the start of the treatment. Or precautions may include necessary medications like diabetic patient, whether heart problem or pregnant women. So pregnancy, usually second trimester is considered to be the safest. So it's better to avoid during the first and third trimester. So these medical conditions are going to influence your treatment plan. Okay, the second factor is the patient's age. No, age, all treatment plans are not suitable for all age groups. You know, there are pedo patients, child patients, adult patients, or it can be an old patient. So few of the examples I have given here. Age can indicate the relative size of the pulp chamber. You know, the size of the pulp chamber, as the age progresses, it calcifies. So there's nothing you can do with the endo treatment, or very young age also will have an effect. So the size of the pulp chamber is one of the influencing factors, or the age. That is because of the age. And one more example is minimum age for extensive crown and bridge can be set as 18 years. See, crown and bridge, what you do is usually reduce the enamel thickness, you know, crown cutting around the tooth. Suppose you have not done endodontic treatment, and if you do it below 18 years for a molar, what happens is the pulp horns are very high. The chances of getting the pulp exposed will be very high. So they say the minimum age for extensive crown and bridge can be set as 18 years. Third one, the patient's expectations. This is obviously very true in case of aesthetic dental procedures like restorative, or it can be orthodontic procedures. Sometimes this what the patient is desiring may be unattainable or unrealistic, or because maybe the patient's attitude or because of the financial concerns. The money is also plays a role here. So this is also influencing a treatment plan. Patient's expectations, what the patient is expectation, maybe sometimes it's not attainable or unrealistic, or patient's attitude and financial concerns will also influence the treatment plan. Fourth one, psychological factors. This is very important for patients with acute infection. You need to modify your treatment plan so that the patient's personality may be needed, so that the patient listens to you and accepts the treatment plan. So treatment must be designed and presented to motivate the patient so that he accepts whatever you have recommended. Just remember to make sure that the patient accepts what he wants or she wants. The chief complaint should be managed first to help establish that the dentist is listening and cares. In most of the times, you have to manage the chief complaint. If there is no pain or acute infection, then it's a different thing. You can modify the treatment plan. Now, coming to existing dental conditions, this is also a factor. You should consider which is the best possible treatment for the existing condition. So it is you who is going to decide which is the best treatment plan to the patient, which will give a long-term prognosis. See, why existing dental condition? One example I'll give you. Suppose you want to give a bridge, or a missing molar is there, lower mandibular molar is missing, and you want to give a bridge that is 6, 7, and 8 as a whole bridge you want to give. Now, the existing dental condition will not allow you to give a fixed bridge. Why? Because maybe these other two teeth are grade 2 mobility. So when they are grade 2 mobile, the 5 and the 7, so you cannot give a fixed partial denture. So the existing dental condition will not allow you to plan the treatment exactly what you want to do. So this is going to influence your treatment plan. Now, this is also an important thing which is going to influence your treatment plan. I have been talking about prognosis since long. So, prognosis of the proposed dental treatment. See, for any reconstruction of the dental procedures, you need to keep in mind at least it should be stable for at least 5 years, minimum of 5 years, except the transitional dental appliance. Transitional means temporary dental appliances. So when you're doing a restoration or some procedure, make sure that the prognosis should be at least for 5 years, means the patient should not have any problems for at least 5 years. So based on these, the prognosis is classified according to the textbook. We have 4 levels of prognosis. So one is the teeth with stable prognosis, guarded prognosis, diminished, and then the fourth one is hopeless prognosis. Now, this is the textbook way of classification. In general, what we usually do for the prognosis is we classify it as excellent, very good, good, poor, or hopeless. This is a simple way of classification, which we do it in our case history at the end of the case history. But this is according to the textbook, so you need to have an idea, just have an idea that we have 4 levels of prognosis according to the textbooks. Teeth with, first one is the teeth with stable prognosis. That means the patient doesn't have any major problems, and the patient can be, the restoration or whatever procedure you do, it can be maintained indefinitely, means it might be staying for another 10 years, 15 years without any problems. The second one is guarded. The word guarded, maybe there are some problems which make them poor candidates for indefinite retention, but can rely for an adequate length of time. I mean, this is also okay. It's not a bad prognosis, but there might be some problems later on with the teeth in or the restoration or whatever treatment you have done to the patient. Third one is the diminished. Diminished means it is less than 1 to 5 years. Suppose you do some treatment, maybe it will not last more than 1 to 5 years. So the dental appliance, it's not going to stay there. So it's not a good prognosis. Diminished prognosis. The last one, hopeless. You cannot do anything. You have to go for removal or extraction of the tooth. So that is called as a hopeless prognosis. Another factor, that is emergency treatment. See, emergency treatment also influences your treatment plan. Sometimes some patients might come to you with severe pain or acute infection, and this, the pain is so intolerable to them. They might ask you to go for extraction. The patient wants to go for extraction. But when you examine the patient and you see, you might feel that this tooth is restorable and you can go for an endodontic treatment and later go for a crown. So what you need to do in these circumstances is you should try to convince the patient, and you should do some emergency endo treatment so that to prevent the loss of the useful tooth, and then you can delay the other care to the patient. But sometimes it's not in our hands. Some patients are very reluctant. They want to remove it and they are very reluctant. In those conditions, you need to take a written consent from the patient that is not willing for any other treatment options, and then you can go ahead with the extraction. But in most circumstances, you should try to save the tooth by doing an emergency endo RCT, that is a root canal treatment, and then the patient, once the pain is subsided, the patient is going to listen to you. The last one, financial considerations and operator experience. Now, these two are also very important factors in the treatment plan, which are going to influence. The financial factors in our hospital, in our clinics, it's not it doesn't matter because it's free of cost. But in private clinics, if you go outside, they have to pay some amount, and sometimes it's very hefty. Patient might not be able to afford it. So suppose you want to plan an implant in the patient, and it's going to be very expensive, and you know that the patient is a suitable candidate for implant. What you need to do is you need to postpone the payment. You can take in installments, like a first visit, second visit, third visit, like that. You can try to do that. Or if the patient is such that he's not able to afford it, then you can think of other treatment plan like a fixed bridge or other less expensive procedure. But better to try to convince the patient to go for the best one if the patient can afford. And also the operator experience. Remember, we have different specialities. Some people might be experienced in prosthodontic work, some might be restorative. So when you think that is, when you examine the patient and you feel that it's beyond my capacity or your capacity, you should not do the treatment. You should refer the patient to a specialist or to the concerned doctor who can do the proper treatment to the patient. So this also you have to keep in mind. Okay, that is about the factors which influence the treatment plan. Similarly, for prognosis also, you have some factors. It's almost similar factors for the prognosis also. And like, the patient's health and all these factors can also be considered during the prognosis. Now, types of prognosis, this is a simple way of classification. See, as I told you earlier, one was the textbook way, 4 phases of prognosis. But here, excellent, good, fair, poor, questionable, or hopeless prognosis. This is what we follow in our case history. So this is a simple way of classification of prognosis. So this is, as I told you before, the factors determining prognosis, same like patient's health, desires, status of supporting structures, condition of teeth, matching of treatment plan with patient's desires or individual considerations. It's almost the similar factors like treatment planning which are influencing. So here also these are some of the factors which also influences your prognosis in the patient. So once you finish all this, the last one is going to be the case summary. And remember, case summaries are of different types. One is the diagnostic case summary or treatment case summary or discharge case summary. What we making you learn in diagnosis is the diagnostic case summary. So what do you mean by diagnostic case summary? It is a written summary of the patient's present medical conditions, and it should be a permanent part of the patient record. Excuse me. Now, diagnostic summary requires the doctor or the practitioner to put thoughts into words, rethinking and reevaluation of the clinical findings to date, and listing of problems collectively from case history with treatment planning options. Means you should be able to recollect what are the main important things in the patient, like starting from the age of the patient, what is the chief complaint, and what are the positive findings collectively, starting from the history till the treatment planning options. At least the important summary, that has to be in your mind. Why this is important is, you have to analyze the case. You cannot analyze the case unless it is there in your brain. So once the purpose of taking the case history is so that you keep some important points or information in your mind so that you can analyze it later during the treatment planning and final diagnosis. So this is the how you learn about a case. It's not just writing down everything and then you go back and look into the case history and then see. But some important points has to be kept in mind as a doctor so that you can evaluate the patient, and then that is called as a case summary. So this is end of the oral diagnosis lecture for final diagnosis, treatment planning, and prognosis. I hope it's clear for you, or if you have any questions, please go ahead. Thank you.